right catheterization, okay, gathers data on the composition, functionality of the heart's chambers, valves, coronary circulation. So inside the heart as well as outside the heart. So what we're looking at is coronaries, which is the blood supply, the heart's own blood supply. Okay, so why would we need a cardiac cath? We want to evaluate coronary artery disease, acute coronary syndrome, sometimes interchangeably used, sometimes accurately, sometimes not, right? Because we can have coronary artery disease can be like a 60-70% stenosis of a vessel that we've acquired over the years, and it's not giving us any symptoms, and we incidentally find it, right? So if it's not giving us any symptoms, people, yeah, there's no real need to do anything about it. However, in acute coronary syndrome, it's unrelenting chest pain, pain that just doesn't stop, it just keeps on thriving. Um, and of course, it falls under the umbrella of ACS, is unstable angina, non-STEMI, and STEMI, of course. We can diagnose valvular diseases, right? If you're having a patient that is having a lot of regurgitation, their feet are swollen, or they're constantly coughing up pink frothy, which is a hallmark sign of uh, pulmonary edema. We can diagnose it through that. Myocardial function, of course, ventricular function. So sometimes when you get a heart cath, the doctor will check the left coronary, he'll check the right coronary, and then he'll go into the LV, inject his contrast, and do what's called the ventriculogram, and we're able to get EF through there. But not always. Not every single heart cath is going to have a LV gram. Okay, so sometimes we get a report from cath lab and they say, "Oh man, they didn't give me fucking EF," or they just said EF normal. Well, that one's different, but they don't always go for an EF. If they don't, if the patient doesn't meet criteria to check for that, then there's no need to do that exam. And of course, we can measure heart chamber pressures. So there's a left versus a right heart cath, right? It's important that you know the difference, and it has nothing to do with laterality, right? We can do a left heart cath through the right groin, through the left groin. We can go brachial on either side. We can go radial on either side. So laterality has nothing to do with laterality of the legs has nothing to do with whether we're doing a left or a right heart cath. Um, it focuses on what side of the heart we're looking at. So if we're doing a right heart cath, we're looking at the right side of the heart, and if we're doing a left heart cath, we're looking at the left side of the heart. Okay, so left heart cath is going to be your most common. If someone doesn't specify that it's a right, it's understood to be a left heart cath, right? Almost always, I can say that with 99% confidence, right? And of course, left is arterial, right? How are we gonna get to the left side of the heart, right? We're not gonna go over basics of anatomy, but in order for us to get to the left side of the heart, we have to go to the aorta, right? So we can't go to the aorta through the vena cava, so it has to be arterial. Even though it might be repetitive, it's very important that you know that. Okay, and of course, if we have an acute MI, it's always a left heart cath. Like I just talked about the LV gram, it will give us our EF. We can diagnose valve disorders. If the doctor goes all the way into the ventricle, he'll inject his dye, and if it scatters all over the place, like to the back and to the front, we know that there's going to be a valve issue, whether it's aortic or mitral, right? So the sequence, and I always, you can use your own learning tools as you want. TPMA is my favorite, and that means toilet paper for my ass. And that's the sequence of the valves.
Oh, yeah.
Tricuspid, pulmonic, mitral, and aortic, right? So you can figure another one else if you want, but that's the one I choose, and that's the one that's very easy to remember. So right at the end of the aorta, not the best picture, but at the end of the aorta, there's two. They're called ostiums, and that's the opening. Anytime you hear the word ostia or osteo lesion. If the you get the report from cath lab and they say, oh, he has a 90% to the RCA osteo. Osteo means at the very opening, right? So it's a very severe lesion. It means it's at the very opening. So if it occludes your whole RCA or whatever vessel, right? So right at the end of the aorta, that's where those are. So one goes left and one goes right. Okay, so whenever we're talking about things like the balloon pump is going to pretty much have two indications, and that's going to be coronary artery perfusion and afterload reduction. There's really no other reason to have a balloon pump other than those two things. Yeah, they can use general like cardiogenic shock, but it's really for that. It's so that in cardiogenic shock, your heart's so weak that it can't have a really tight aorta. Otherwise, it's not going to push through. So real quick, we'll talk about acute coronary syndrome. Just a real quick review. This is not the focus of the presentation, but we have unstable angina, non-STEMI, and STEMI, right? Unstable angina, of course, is chest pain at rest. It's not predictable. Nitro may or may not fix it. Sometimes people tend to take, they take one pill, 5 minutes later, they take another one and they'll get relief. And then, of course, if at the third one they don't get relief, they need to go get help. So you teach the patient at minute 0 is your first pill, minute 5 is your second pill, and at minute 10 is your third pill. And if that doesn't help, then it's probably an MI of some sort, right? Usually troponin is going to be negative, and they'll have a ST depression or a T wave inversion, which are ischemic changes to the EKG. Typically, they stop the activity, whatever they're doing. It gets better, but with these patients that they're having just unstable angina, they're just like chilling, watching a movie or whatever, and they'll just get that severe chest pain, right? Non-STEMI, unrelenting just means constant, doesn't stop, there's no relief. They'll be troponin positive, and of course they'll have ST depression and T wave inversion. Non-STEMIs are kind of like the oddball of these because some do get PCIs, PT intervention, PTCA, balloon or whatever. Some don't. Sometimes they just have to treat the underlying condition, whether a lot of patients with like DKA, they end up getting it because they get stressed out. That's why whenever we get patients with DKA, there's all this shit that we have to do because we have to figure out what caused them to be in DKA.
So like what is it, like acidosis or
whatever acidosis? Yeah. So let's say I have a 80% lesion that I'm unaware of, and as long as I keep my sedentary lifestyle, no pasa nada, no big deal. But let's say, man, all my friends have 6-packs or whatever, and I want to be part of the crowd, so I'm gonna go from couch, Netflix all day to CrossFit, right? So then now my 80% vessel is not gonna be enough for that oxygen demand that my heart's requiring. And that's pretty much where the chest pain comes from, right? So with coronary artery disease, it's very important that you know that you can't solve these patients' pain with Tylenol. You can't solve their pain with Motrin. You can't solve their pain with warm compress. You have to know in your head, and being a prudent ICU nurse that you are, that their heart is suffocating and it's telling you it needs oxygen, right? And you need to decrease that oxygen demand. So one, they'll get Mona, right? Or Onam, whatever is the latest. But combination of those, right? They need whenever your coronaries get any sort of injury at the cellular level, they trigger, right? Just how you would trigger swelling here if you hit yourself, they trigger, and what happens is that they'll get their platelets will aggregate at the site. And if I have an 80% lesion there already, and now I'm inviting platelets over, so that's where the aspirin comes in and the nitro dilation. We need to make sure that we avoid that platelet aggregation. And of course, oxygen, they need rest. and then we need to search for other things. But they don't always uh, get coronary intervention, non-STEMIs, right? So sometimes it's important that you know that that's how non-STEMIs are treated. It's important that you know that if you get a non-STEMI from the ER and there's nothing done to them, according to you, just know that there's nothing that really can be done, right? Because it's not an acute closure. Moving on to STEMI, right? STEMI is going to be an acute closure. 100% of the times, it's an 100% blockage that's causing severe enough ischemia to actually affect to make bigger EKG changes, right? ST elevations, the tombstone pattern, the little firefighter hat, whatever, and that's really the two basic rhythms that any new nurse coming into the ICU should really know and recognize is your fireman's hat and your tombstone pattern. If you don't recognize any other rhythm, it's absolutely important that you recognize those. And then troponin positive, of course. And then we're going to have ST elevation in 2+ contiguous leads. So the term leads and electrodes can be used interchangeably, but it's technically wrong. So we have, for a 12 lead EKG, we have 10 electrodes that give us 12 leads, right? And it's all from this formula triangle, and we have what are called virtual leads. So lead 1 would be like right here to right here, and lead 2 is right here to right here. Even though we do use, like, oh, I'm going to change my patient's lead, it's actually, I'm going to change my patient's electrode, right? And they all got to be together because otherwise they don't communicate with each other. So just know you're placing 10 electrodes to make 12 leads. So one of the topics that's lately been come up and like a lot of like on the Facebook posts and things like that are why can't we make wireless EKG, right? And the answer is we could, but we would need to have like each electrode would need to have its own electric component, right? So you would have like huge electrodes because they need to be in constant communication with each other. Otherwise, they don't make those virtual leads. I know the closest we've gotten is to make where you connect all the wires together here, and then the whole module is wireless, and you can keep the EKG machine outside, and then those just from here to there they communicate with each other. But all the wiring is still going to be, even with the telebox, it's still wired to the patient, and then the telebox itself to whatever antennas. But it needs to be in constant communication, and very important that you know lead placement, right? But we're not here to talk about lead placement. So once we get a STEMI, we're going to do what's called a percutaneous coronary intervention, and that's kind of like the new umbrella term of any intervention, right? So PTCA or stenting, it all is going to fall under PCI. So we use a balloon to dilate the artery to improve or restore coronary flow, right? So we have a patient and we do a diagnostic cath, and he has maybe like a 60-70% lesion, and he's getting somewhat a little bit of chest pain. He'd like to feel better, so they go in there, they restore the flow, versus if it's an acute STEMI and acute closure, it's going to be considered improve versus restore flow. So 70% lesion, improve flow, STEMI, restore flow. Of course, reperfusion, and it can be with or without the stent. However, anytime that we do inflate inside the coronary vessel, we have the risk of dissection or rupture, of course. Patients may re-occlude, so the procedure may need to be repeated, and you have those patients that keep on coming back and coming back and coming back. Sometimes it's a non-compliance thing, sometimes it's hereditary. It's just the vessel just doesn't like the stent there, So most people get that way because we have 60, 70 years of you just being like that, and all of a sudden you're going to go from a 70% lesion to 0, and your heart's not used to it. So many of the times they'll need a stent. The doctor goes in there, balloons. The majority of the time, the balloon itself does not resolve. right? The vessel tries to go back to where it was, even though the fat's already been displaced. So they have to go in with the stent. So it's important that you know that whenever they go in with the stent is inside the stent is a balloon, and then they go in there and then they inflate the balloon, and then the stent. They try to make it as tight as possible in the vessel so that it doesn't migrate, right? If your stent migrates, you have a different kind of an issue. You have a different type of medical emergency. And of course, always, you need to let the patient know that they need lifestyle changes. They need to stop smoking, they need to stop drinking, they need to stop eating like shit, um, all those things.
Jose.
Yeah.
I know you're gonna touch up on the
Mhm.
post PCI, but something that I found out later in my ICU career,
Mhm.
and it wasn't until I started floating onto cath lab that I found out. During the PCI, I know I would always they would give me a report from cath lab,
Mhm.
like, oh, patient got 5K of heparin.
Yeah.
I would always overlook that, but that's why post-op is very important because you don't know what goes on in the actual procedure, right? And I think if you familiarize yourself with that, is that they give so much anticoagulants in there,
Mhm.
10K, and I know the half-lives are not that long,
Yeah.
but as a bedside nurse, I think it's important to understand that while they're in there, because it's so important for the PCI, the actual PTCA, to be anticoagulated.
So they need to be anticoagulated because there's all these devices in there. And your body doesn't like it. So it's going to try to clot it. So they need anticoagulation. So post-op, they're going to come back to the unit, and then you'll have like little bleeding issues, little hematoma issues, and then they're also going to be running a systemic heparin drip, right? And that's so that we don't aggregate those platelets, right? That's why we don't have brand new foreign material, like I said. So whenever you push anything into your vessel, especially the intima of your vessel, it's going to inhibit like cytokines and all this other like nerdy cellular stuff that are going to try to invite over platelets, and platelets are going to be your number one enemy. So whenever you're getting a patient, like if they're a GI bleeder, I know, and this is a constant battle between GI and cardiac and everyone else. If your patient is post coronary stent, like they need to keep taking their Plavix. I know initially you have like a massive GI bleeder, your GI doctor is going to come and is going to say, stop Plavix. Because, of course, right? That's going to, whenever the way Plavix works is that it binds to the platelet and it essentially makes it ineffective. And platelets live like 10, 11 days. So, and there's no reversal, right? Once you take, that's why they'll say, oh, don't stop taking your Plavix for like a week before surgery, because they essentially want those platelets to die off so that new baby platelets go on and they don't have the Plavix bound to them. So it's as a bedside nurse, it's important that you know, like if a GI doctor cancels your Plavix and your patient's like post STEMI, and a lot of the times it happens where they're STEMIs, they get stented, they come in here, they're on pressors, and then they start pooping blood, and then automatically, so it's as a prudent nurse, just know that you're going to fail that patient. You might save him from his GI bleed, but he's going to restenosis, and now you're going to have those EKG changes as well. And it doesn't matter. Let the doctor know, even if you notice it late, just say, hey, I noticed fucking 3 days ago, fucking Javi DC the Plavix because ex GI doctor told him to do so, and I noticed that the patient is now having ST changes
what
or
you're saying
EKG
is like,
changes.
you get a GI bleed,
Mm-hmm.
always like kind of have that in the back of your mind, like, hey, it's a GI
In the back of your
bleed,
mind that it's a
cardiac
GI bleed,
problems.
and sometimes we can't do anything about it. We have to give both concurrently, right? And that's the whole point of interdisciplinary care. That's the whole point of ICU, being in the ICU setting. Compared to medicine, ICU is very new. ICU has only been around since the 1950s. Any patient that's here, any true patient that's here, prior to 1950s, they'd be dead because that's where the care ended. You know what I mean? So it started from uh, post-operatively anesthesia had to stay with the patients with complications. And one day they said, fuck this, let's train some nurses to do this. So that's why many of the times, like you're able to talk to the anesthesia doctor or the CRNA because essentially like the titrating of the pressures and the drips is an extension of that of anesthesia. So that's where it stems from. Initially, yeah. So your first ever ICU was in Copenhagen. But just so you know, little ICU jerk off
That
porn.
was the Nazis.
We had to.
Yeah.
Find out. That's how we're so advanced with like prosthetics because of the war, right? People get blown off, and now they're that. Now there's robot arms, and they had like in anywhere from like 2008 prior, they didn't teach us any, like in the military, they didn't teach us anything about stopping bleeding. So most people were dying from stopping bleeding, and then someone got in there and they're like, man, all I had to do was this. And my buddy would have been alive, just didn't know what to do. But whatever. Now it's common knowledge. Okay, so post PCI interventions, right? You got a little fill in the blank. Make this presentation super fun. Anticoagulants and antiplatelets post PCI are to prevent thromboembolism, right? The bone endothelial damage, that's what it's for. IV nitro, very common misconception. Post PCI, it's never for BP management, okay? It's to avoid coronary spasm. And it's very, very important that you know this. If your patient's hypertensive, you call your doctor, you tell him, hey, you want to push some hydralazine, blah, blah, blah. Or sometimes they'll tell you, oh, if I could just go up on the nitro, right? And if that's your order, then that's your order now. But essentially, the initial reason why we have patients on IV nitro post-op is to avoid coronary spasm. We want to keep that vessel nice and fat or dilated.
Is there anything like, for example, I've seen it here before, where your patient's very hypertensive and you go up to, some of them I've seen it, they go up to the max dose.
So once you start
effect?
learning like, they'll get like rebound hypertension. They can get bradycardia once they go like super high, right? And they can also get tachycardia, right? There's like no rules to these things. There's many things can happen. So sometimes you'll call a doctor for something, and he knows, right? Because he has his doctor brain, and he says, "Well, yeah, that's an expected finding." So, oh, fine. And then you hang up, or he'll tell you, "Oh, yeah, that's fine." And then you hang up, and you're like, "Man, this guy doesn't give a fuck," And that's not necessarily true. Sometimes it is, but not always, right? And so we should always assume that everyone always wants the best for our patients because that's the initial thing that we're here for. Nitro, in my experience, and many nurses will tell you, typically if you go past like 50, anything after that, we can go as high as like 200, I think is the max. But usually after 50, like it's not going to do any much more. So typically if you go once 50, and that's something usual that once you become a prudent, expert nurse, you get to 50 and you'll phone the doc. Like, hey, I'm at 50, like, you want something else because this ain't cutting it, And it's also inconvenient. I'm spiking the bottle, like if it's like a big person on propofol, and I want my shift to be chill. So, do you want to start something else? Whatever, okay? And then fluids, the reason we order fluids is to flush out that contrast and that dye, right? The metformin deal is 1 day prior and usually 48 hours after, right? So like I said, this isn't gospel, and many of what we do in the ICU is not gospel, right? It's plus or minus anything that you're told, right? So some people will say 36 hours and some people will say 3 days, but just a ballpark, 1 day prior, 2 days after. Reason being is the metformin and the contrast, they interact and they might give you acute tubular necrosis which can lead to renal failure. Um, there's like some studies now that are saying if your creatinine is fine, this isn't an issue, but whatever. That's just so that you put in the back of your head.
We're
This-
talking about holding.
Sorry, go
We're
ahead.
talking about holding my form.
We're talking
right?
about holding metformin or just morphine. Oh, sorry, metformin administration. Um, you to be prudent if they, sometimes they'll hold it and they won't start like insulin coverage. Typically, most of the protocols do, but not always. So if your patient's on metformin and they take like 2,000 a day, just know that you have to be on it. And the minute if they give you like an order for a low scale of like regular insulin, the second screen the blood glucose check that you do, take it upon yourself to be like, hey, you want to go to like medium of Lispro instead of this regular garbage that we're giving because it's not working, and this patient is always eating carbs and family is like sneaking in snacks. So what you don't want to do is you want to avoid insulin drips. What's up?
As a bedside nurse, is there something I can do to, example, patient develops chest pain today, EKG changes, patient's on metformin today, I gave it at 9 a.m.,
Mm-hmm.
it's 1 p.m., the doctor says prep them for cath lab tonight. Is there something as a bedside nurse I should tell the doctor, like, hey, patient's on metformin, is there something you want to do about it? What's the treatment regimen for that?
Well, I mean, it's not going to exclude you from the procedure.
Yeah.
You know what I mean? Like, it's not going to be like, oh man, I have my metformin, I'm 90% stenosed, nada mañana, you know? So like I said before, it's not gospel, it's not an absolute contraindication. We have patients that are allergic to contrast, they're allergic to shrimp, they still get a hard cath. We give them Benadryl IV, we give them Salumedrol, and if they anaphylax, we'll give them epi drips, whatever. So, but it's a good thing to mention, right? And then, so there's the newer studies about acetylcysteine that doesn't really work for acute tubular necrosis prophylactically. So it's one of the things that's like kind of getting like debunked now. So out of here. Just like renal dose dopamine, out of here, not a thing. We used to put patients on, when we put them on a vent, we would do like 10 mLs per kilo. So we would have tidal volumes of like a liter, 1,200 mL, fuera. All those things are so, and we evolve as a science to know later be like, man, I remember antes we used to, and sometimes you still do. We have patients, like we have some doctors sometimes that they'll emergently intubate, and the last time they intubated was like in fellowship, fucking 60 years ago, and they give you vent settings, and they're like, oh yeah, tidal volume 800, and it's like a 45 Rowena, right? 45 kilo lady, right? So you'd be like, okay, doc. So that's whenever you come up and you advocate for your patient and say, hey, we typically do this. And after this, we'll go over mechanical ventilation so that you know what's like the norm recommendation, okay? And of course, you educate your patient to adhere to the medication regimen, risk-free occlusion. Before your patient leaves the hospital, we're almost not always going to see discharges from the ICU post PCI because they're typically going to go to the floor. But it's important that before they go, and they're a brand new stent and they haven't already been on Plavix and aspirin, that they get a script, right? You'll set them up for failure. You tell them immediately to get that filled. Hello.
Hey, what's up?
Sorry. Oh, yes. What
No.
other time do you do the other class?
At 12.
At 12? And then from
Yes.
the last one?
I don't remember.
3:30.
Like 3:30, I think. Yeah.
You look so pretty again, Cynthia. I love your hair. Anyway,
What's up?
Good.
Oh yeah. Cancel that last. All right. She didn't know we were recording. So, anyways, post-op cardiac cath, we're gonna monitor vital signs, rhythm. I think I spelled that right? That's my least favorite word is rhythm. Assess for chest pain. 3 S's. Ooh. Monitor pulses distal to the insertion site. You notify your doc if it's cool, pale, cyanotic. Pulse this extremity. You compare it with your second one, right? You get a history. Sometimes we have patients that have severe PVD and they're already cool. So you call the doctor and he'll be like, "Yeah, I know." So make sure that you know a little bit about your patient's history. So something that as a new nurse you might miss is, so as a new nurse you're going to be task oriented your first year, and you'll get out of that at best at 6 months, right? So that's very oriented on the task, right? So me and someone that's new will see the same situation differently, right? So and they can't help it, and that's fine because that's part of you growing. Um, so if you're very extremely like task oriented, you won't focus on the other leg or things like that. Your focus is just like, damn, this leg is cold or whatever. And many of the times, what we miss when we're very task oriented is, why is a patient here? And that's very, very important. Whenever every single patient that you have, you must know why they're here. I mean, and it seems like it's common sense and second nature, but many of the times we go into the room and we're new, we get overwhelmed by, like, there's drips and there's like tube feeding and there's like you're getting report, and then you have like the classic, right, that your patient's leg is down and they're like, oh, he's been so chill all shift, and you know that leg outside of the bed, that's a bullshit report, right? So you'll focus on those things and you're like, man, I'm gonna have a hard time with this patient and he's intubated and I can't sedate him properly, and you'll go over your orders and blah blah blah, and then you never know why your patient's here, right? So it's very important that you do know why your patient's here. You monitor for hematoma, of course. Sometimes cath lab will tell you, oh, he developed a little one, or he has a big hematoma. So it's very important that you go in and you assess your patient. Initially, when they come in, every 15 minutes, right, for like an hour or a half hour, and then like 30 minutes, you need to keep checking. You need to keep checking again and again and again and again. And every single time that you go, it's going to be a new a new experience or whatever, because 15 the patient can move a little bit as soon as you leave the room, and by the time you come back 15 minutes later, there's 15 minutes of hematoma that have already developed, right? But it's very important that you go and assess, again and again and again and again. Okay. If you're tell the patient to keep the extremity straight, we want to avoid arterial occlusion, especially when they're femoral. The way our body's made is, if we bend a little bit, our whole thing bends like that. So if you have a sheath in place, one, it will occlude your artery, and of course, if it's severe, you'll perforate your own femoral with your sheath because it's rigid. So if you have an A-line and femoral, with the A-line, the patient can sit up because it's like a silicone thing, like an IV. But if it's a sheath, the sheath is rigid, and you can't sit with those. Whether it's venous or an arterial, if it's a sheath, the patient cannot. You can't bend past 15 degrees. Okay, and then immobilized limb if brachial or radial side was used. So one of the little flaws that we see in whatever happened with that big hematoma is that there's never a mention that the patient's arm was immobilized, and that's very essential so that the patient doesn't develop. So post radial cath, yeah, the patient can sit up. That doesn't mean he's free to do whatever they want, right? So now they're going to give up that liberty of using this arm. The less they move it, the higher the success rate is.
What happened with that hematoma? I wasn't here.
I guess they developed a hematoma, and right now we'll go over like that scenario. So we'll see what happened and how that's probably going to fail every single time. So yes. So what if we can't do a PCI on you, or we can't stent you, then you're gonna go get a cabbage, right? Coronary artery bypass graft. And right here we have how it kind of looks like. They'll harvest your veins from either your legs, your great saphenous vein that we have here. We have two of them, and then if that's not enough to do these bypasses, then the doctor will take your radial artery, yeah, And then, of course, we can always divert your native vessel, which is the lima, or the has another name like a LICA, right? Internal costal artery, but everyone knows it as the lima, and it'll probably be like 50 years before we not call it a lima. So just know that this vessel here is native, so it's our own vessel. It just gets diverted, right? And it almost always goes into your LAD. Your lima does 90. It always goes into your LAD. All right. So who qualifies to get a cabbage, right? Of course, chronic disabling. There's more reasons. These are the ones that I want you to remember. Chronic disabling angina, unresponsive to medical therapy, which is refractory, right? We do something and it doesn't work. We call that refractory, right? We'll have refractory hypoxemia, like in ARDS, but that's what refractory means in a nutshell. And of course, and that they're not no longer a candidate for PCI. So you have these patients they have 6, 7 stents, and really like there's no space anymore for more stents. They're no longer a candidate. They're on nitro. They're on a nitro patch. They'll have like they're on like labetalol. They're on all these meds and it's just not working. They're still having chest pain, right? So that's one. Left main lesion is going to be your other indication by itself. If you have a left main lesion very high, that includes your whole left side. It includes your circumflex, uh, your whole left side. So left main lesion by itself is a candidate in itself for a cabbage. And triple vessel disease. That's going to be your most popular one right here. 3 vessel disease. Yeah, sometimes there's other indications like if let's say the interventional cardiologist is deploying a stent and the stent migrates, it goes and it's not tight enough and it just flows through, then someone has to go manually get it out and fix it, right? And once they're there, they'll typically do a cabbage on you. Yeah. So complications, of course, infection. Anytime we compromise our skin integrity, we're gonna have risk for infection, bleeding, right? So that's a great Turner sign is the flank. You get like this color, the flank like purple bruising, and that's an indication of retroperitoneal bleed. That's what the great Turner sign is. If you have allergy to contrast media, like I said before, you're gonna receive steroids, antihistamines. It doesn't mean you get disqualified from getting the cardiac cath. And then postness distal to the insertion site. Not so common, but kind of common when you have like a bigger sheath, like an impella. That's very important. Distally, you have flow. Of course, perforation of heart muscle. They go up there, do a little oopsie, they go too far. Stroke and death, right? And this is all typically in their consent. All right, so now we're going to go to the right heart cath. Like I said before, it's going to go on the right side of your heart. So this one is going to be venous, right? So, and same thing. It doesn't matter from what side they go in. They can go into the left side or to the right side. Many of the times, if they do a left and a right heart cath, they put both sheets in the same side. One's venous, one's arterial. So we use this to diagnose congenital heart disease. Typically in the ICU, in the adult ICU setting, that's when you get a patient and they're older than 18, they're more than likely already going to have this diagnosed. But if they develop like a shunt or anything like that, this is an indication as to why we can do the right heart cath. We can measure cardiac output, hemodynamic pressures via the Swan-Ganz catheter. So Cath Lab has their own super long swan that they'll go from here, and the way we measure these pressures is with the swan. This right here would be a swan, and they would go all the way in there. They would get their pressure measurements, and then the whole swan will come out the majority of the time. And we can also assess for pulmonary hypertension with the same catheter. And as well, if we have to emergently pace a patient, we're going to use it through a right heart cath, and we're going to introduce it We're gonna go all the way into the RV, and then your patient's gonna sit in there, right? And their patient's gonna come out, and they're gonna be connected to a little box. Okay. Speaking of cardiac pacing, real quick, we'll go over the pacemaker code and what each letter is, so that you know pacemaker code. Okay. So the very first letter in your pacemaker code. By the way, they'll go up to like 5 letters now, but at the bedside setting as emergent pacers, you'll typically go up to 3 letters, right? Sometimes if you have a patient with an actual pacer and you have all the info, those are like really sophisticated. They're like titrated to that patient, so they'll have like 5 letters typically. But we're only going over the first 3. Okay, so your first letter is what chamber is being paced, right? So you're gonna have either an A, V, or a D, which is it's either in the atria, the ventricle, or it's in both, right? The second letter is gonna be which chamber is sensed, and again, you're gonna have either AV, dual, or none, right? We can have such a thing as we just want a patient to do this, so we don't need to sense anything, all right? And then the third letter is when the pacemaker detects your intrinsic beat, which means the patient's own beat, what is that pacemaker going to do? It's either going to trigger a pacemaker beat, it's going to inhibit it, and this is when we inhibit, that's what's known as an on-demand pacer, okay? And then if we can do inhibit and trigger, or we can do nothing. So your most common modes that you're going to see here is going to be VVI and DDD, right? So along with this, you'll have like a rate. So it'll be like VVI 90 or DDD 90, whatever. DDD like 60 typically, or 70. So here we have our first letter, so it tells us we're pacing the ventricle. We're also sensing the ventricle. And if my pacemaker detects that my own heartbeat is above my threshold, let's say I have a VVI mode of 70. If my pacemaker detects that I give a beat at 80, it won't pace me. But if I drop below the 80, it will pace me. That's what's on demand, because since it's not detecting my own beat, there's no need to inhibit, so my body's asking for it. So that's when the demand function comes in. It's only demand is based on what your heart needs. And we will typically use these for AFib. So VVI, you'll typically have a higher rate. Like VVI will be like 90, because it's typically for AFib. Upstairs, they're doing whatever the fuck they want, and we care about downstairs, right? We care about the ventricles, right? Because we're fine with AFib, but we're not fine with VFib, right? It's unanimous. So we'll typically put, for AFib, we'll put VVI typically at a higher rate, like 90 is like the usual one. And then if we have DDD mode, the way that works is you'll sense both chambers. We'll pace both chambers. We'll also sense both chambers, and then based on that response. So let's say this one is used for AV nodal dysfunction, so third-degree block, where the divorce beats. You'll have we'll pace the atria, and if the atria is enough, we'll pace the SA node, and if it's enough that travels correct, then the bottom part won't pace, because the SA node travels to the AV node Purkinje, and then everything's good. So then there's no need for the ventricles to be paced. But if it doesn't, if we pace the atria, nothing happens, then we gotta pace the ventricle. So that's where this dual function mode is. So it'll both inhibit a trigger. It'll inhibit an impulse, or it'll trigger an impulse based on what it does. So it has to be based on if the atria works fine, it travels correctly to the AV node, travels correctly, then it'll only pace your atria. So you'll have, for the AV node dysfunction, you'll have not always will you have 2 beats. Sometimes you'll have 1 only, and sometimes you only have a V1. Sometimes the atria on its own is fine, but it doesn't travel correctly, so then it'll just pace the beat. So that's the whole point of the DDD mode. And with the DDD mode, you'll typically have like the lower one, maybe like 60 or so.
Was it, how would a new nurse interpret an external pacemaker like this, or internal,
Mhm.
to a transcutaneous pacemaker that we're using the Zoll with? So I know like trigger and the inhibit and all that kind of stuff. We can correlate those with what settings on the Zoll monitor, let's say.
So whenever we're using, so like I said, this is just reviewing like pacemaker code
Yeah.
and not necessarily like all pacemakers in
Yeah.
general. But one of the settings in the pacemaker is going to be your amplitude or your milliamps.
Yeah.
So just know that your milliamps, whenever they're transcutaneous, are going to be much higher because they have to travel through skin, bone, all that shit, you know?
Oh, thank you. Yeah.
Right? They have to travel through skin, bone to get to the heart. So it's gonna be much more energy required to do that. Whereas this one, it's it's inside the heart. So your milliamps are gonna be way less. Patient probably doesn't feel it. So just know that the energy required for like a pacemaker that's inserted via right heart cath in the RV will have maybe like 10 or like 15. And just know that transcutaneous pacing is going to be like 40, 60, because you have to effectively pace the patient that way. Otherwise, it's not gonna work. So yeah, so for transcutaneous pacing, you're gonna have to crank it up way higher, and patients not gonna like it because they're gonna feel it. So that's separate for like sedating, blah blah blah, whatever. But just know that. Magnet. Theory around magnets is do you know what this magnet does? You know what it is?
It stops the pacer.
Okay. So it's incorrect. And that's a common thing, and sometimes it's taught because that's what we were taught. But your magnet does not stop the pacer. If your patient is comfort measures or anything like that, there's no need to put that on the patient. What the magnet does is that when you put it on the pacer, it will make the pacer behave asynchronously to whatever setting it is. So with a Medtronic pacer, you'll put a Medtronic magnet, and it will make that pacer behave a certain way. And with Medtronics, it's VVI 85. So it will change your patient's pacemaker rate to VVI 85. As soon as you take the magnet off, it goes back to whatever it's programmed. But that's a very common misconception and I mean, I was taught that too, that it's to turn off your pacemaker.
It just sets it to default.
It sets it to pace asynchronously, so your patient is always going to be on whatever that is, whether he's scared or whether he's laughing or whether he's chilling, he's always going to be on. With Medtronic, it's VVI 85.
So what are you trying to achieve at that point? Like,
Whenever we use these, whenever we put a brand new one, so sometimes you get orders for EKG with and without magnet, and that means whenever we put a brand new one, we want to make sure one that it works and one that it can follow commands. So since we already know that if we place this over the device, we're going to be at VVI 85, and you place it and you do an EKG and you're at 85, we know that it works, right? So if it's a pacer, it will set it to that. Now, if it's an AICD and you put the magnet over it, it will no longer correct an arrhythmia. It will no longer do what an AICD does. So in that sense, it will turn off an AICD from the function that it does. Because AICDs only function with lethal arrhythmias and stuff like that. AICDs are not always working. Now there's dual function pacer / AICD, but we talk about them separately. For if it's a pacer, it'll go to with Medtronic, which is the ones that we use here in Laredo. You're gonna see VVI 85 on a pacer, But if you put it on an AICD, it will no longer correct an arrhythmia. Um, if you have a patient on comfort measures, your patient's not going to pace forever. Just know that you don't need to put anything on the patient. You don't need to worry about not correcting an arrhythmia. Uh, if a patient is pacemaker dependent, it is unethical to get rid of that function because essentially it's their patient's lifeline, and it's not up to anybody of us for sure to withdraw that life from them. They need to die natural causes, and so it's out of ethics too. You can't call you can call Ryan Abdullah and he'll tell you to go fuck yourself if you tell him to go if you tell him to turn off the pacemaker because then he'll tell you that it's out of ethics. If a patient even when they're hospice and DNR, they'll put them at a lower rate, but they won't turn it off. If you're pacemaker dependent, it is unethical and illegal to turn off a patient's pacer. So just know that the magnet on a pacer, BDI 85, magnet on an AICD will no longer correct the arrhythmia. But there's no need, if your patient's on comfort measures, there's no need to put a magnet over this device because eventually if your heart becomes ischemic, it'll no longer receive the impulse, right? If your patient's dying from whatever it is, MI, ARDS, like the patient's not keeping them alive forever, right? Eventually, when your heart becomes ischemic, it's going to become tough, rigid, fibrotic, and the impulse is no longer going to generate, right? Dead meat, don't beat. That's what you have to remember with pacers. Once it becomes very ischemic, it'll no longer, the impulse will no longer travel, right? All right, so this is the TR band. It's made by Terumo, and it's the radial artery compression device, right? It's the device that you're gonna see here is the only device that we use for radial hemostasis. It's transparent. There's two band lengths. There's a regular one and there's a large one. It has Velcro, and it's very important that cath lab gives you the syringe. Okay, I'm sure you can get like a slip tip in there, but it's meant for this and this only. So, two things that very important that you get from cath lab on report is how much air they put in here, right? Because you need to know how much to withdraw, and that they bring you that syringe.
When they came with mine, they actually taped it to the wristband.
Great, but it's just that
Make sure
it has to come with the patient. Yeah. So I have a little. I don't know if this video is gonna work. I think it did. Yeah. So to just talk about how it's placed.
My name is Dr. Michael Martinelli from St. Peter's Hospital in Albany, New York. Today we're going to be discussing the application and removal of the TR band. The TR band is used to apply low pressure hemostasis at the site of the radial artery access and sheath. We'll discuss the importance of the Barbo and the reverse Barbo test as it pertains to placement of the TR band. And the reason why we maintain low pressure or paid hemostasis is to attempt to reduce the incidence of radial artery occlusion following radial artery catheterization and angioplasty. Although radial artery occlusion is thought to be rare and mostly asymptomatic, it is important when we are dealing with re-access of the radial artery at future time. Low pressure hemostasis or patent hemostasis enables blood to flow through the radial artery while compression is applied in order to reduce the likelihood of radial artery occlusion. To assist with managing hemostasis, Terumo has developed a dual balloon radial artery compression device designed to help manage the cessation of bleeding from the access site under low volumes of pressure. In addition, the TR band allows the user to control the pressure applied by incrementally titrating air throughout the recovery period. The TR band is unique in that it can manage two important elements concurrently and consistently: hemostasis and maintenance of low pressure. After removing the dressing, we will withdraw the introducer sheath about 2 to 3 centimeters in order to properly place the band on the patient's wrist so that there is no obstruction when seating the band. The TR band must be positioned differently when used on the left or right wrist. When attaching the device, ensure that the Terumo logo on the support plate is closest to the patient's little finger or ulnar side of the wrist. It is also important to align the green marker about 1 to 2 millimeters proximal to the puncture site and fix the strap on the wrist with the adjustable fastener. The green dot is located on the center of the compression balloon. Placement of the green dot is important because it ensures that the balloons are appropriately located on the radial artery to control bleeding. Now that the band location is properly secured, I will fill the inflation syringe with 15 to 18 mLs of air and slowly inject the 15 to 18 mLs of air into the air port of the TR band and simultaneously remove the radial sheath. The air will be fully inserted when the sheath is completely removed. The goal is for bleeding to cease when the sheath is completely removed from the patient's artery. Once we have fully inflated the TR band and confirmed that bleeding has stopped, we will now ensure patent hemostasis. We will do this by removing 1 cc per second while keeping an eye on the access site to watch for bleeding. Once we see a flash of blood, we will inject 1 to 2 cc's of air back into the balloon incrementally until bleeding stops. This will help to ensure patent hemostasis. This again can be confirmed with a reverse Barber test. The patient is now ready to go to recovery. When it is time for the TR band to be removed, we will begin by removing the air of the balloon to check for hemostasis. I will start by removing 3 to 5 mLs. Since I have not seen any bleeding, I will continue to remove air from the balloon. If bleeding is still seen, we will insert enough air to restore hemostasis and once again confirm patent hemostasis. After 15 to 30 minutes, the removal process can be repeated. Now that air has been completely removed from the band and bleeding has stopped, we can unfasten the Velcro band, slowly remove the TR band by lifting toward the palm of the hand, and lastly, applying sterile dressing.
That was like the worst sterile dressing application I've ever had. Sterile. Well, that's sound.
Eso de ser en el cigarro en este tipo.
Solo ones. Wow.
All right. Do we have a like a policy or a protocol for this here?
Mhm.
Has anyone mentioned like a plan for it?
No. I'll give you everything we do at the clinic,
Yeah.
and then you all do whatever you want. Eso no lo pongas.
Good.
Sheath, post-op sheath will be removed. So sheath will always be removed in cath lab. Reason being is that your radial artery is more sensitive. The intima is way more sensitive, and that's why they're talking about radial occlusion, because that's what the biggest complication is, that radial occlusion. So whenever the doctor accesses the radial, he injects verapamil uh, to avoid spasming, and then also injects a little bit of nitro as well to dilate, and then they always get heparin, whether it's diagnostic or not. They always get a heparin bolus, a small one. It's usually like 4 or 5 K, um, just to avoid any aggregation around the site. Because the biggest one, if it spasms, like the doctor can't pull out the sheath because it just hugs the sheath like that. So that's the reason for the verapamil. It's like a little cocktail verapamil, depending on who it is. Um, Dr. Ricardo Jr. likes to use only Ricardo Jr. and Joaquin are the only ones that you'll probably see do radials. So um, Joaquin will use like 5 of verapamil. Every now and then he'll use nitro, and then Dr. Ricardo Jr. will use like 2.5 of verapamil and 200 mics of nitro. But they all use heparin. So, so anyways, removal guidelines. Okay, so the TR band will always be removed in cath lab. It has to be done by like this whole video, the majority of it is for the doctor, right? They remove it, they do the patent hemostasis, and then he'll inject X amount of mLs. So that's written in your report, that when you get a report, TR band, and they'll tell you, oh, they put 12 mLs or 16, whatever, 15 ml, whatever amount. That one's very important that you have that on you. So removal guidelines, if they received heparin 50 units per kilo or less, the band remains in place for 60 minutes. And if they receive for more than 50 per kilo, then it'll remain in place for 2 hours, sola, without you messing with it, without doing nothing. But it's important that you immobilize it. Us at the clinic, we immobilize it immediately.
What do y'all use? Like
Just a regular, like a
radial,
like a little radial split.
Immobilizer,
Yeah, it's
yeah.
literally just a little board with 2 Velcro straps. Like it's not like the A-line one or anything.
Oh.
It's just rigid.
And it's just for the forearm, is it the forearm?
It's just from like here to here.
Okay.
It's just this long. So if you have a giant hand, it's only for your hand. And you've got little baby arms, it's the half of your body. Yeah. So but it's like maybe 10 or 11 inches long. Very simple. And we try not to get it dirty because we send them home with it too. So in a nutshell, what probably the true guy is going to tell you, if it's a diagnostic cath, it's an hour. If it's a PCI cath, it's going to be 2 hours. So then at the 2 hour mark is when you start removing your air, right? So step 1, whenever your patient comes back from the cath lab, you're going to put your O2 probe on that hand. Your oxygen saturation probe goes in that hand to confirm the patent hemostasis, right? So that's what he's talking about. And that reverse Barbaro test or whatever he calls it, what they do is they'll be on the pulse ox, they'll inflate till they lose waveform, and then they'll come back till they get a waveform again. And that's what that test is, pretty much. Step 2, remove 3 to 5 mLs every 10 to 15 minutes after the initial time has passed. So 60 minutes versus 120. Right. So these are Terumo's guidelines, right? They're not mine. They're not made up by myself or anything, right? Step 3, if bleeding occurs during the removal, you just shove air back in until you stop the bleeding. And that's it. You don't have to wait. You don't have to get an order or anything. If you're removing air and you have some bleeding, you just shove the air back in. So step 3, like I said, you insert enough air to restore hemostasis, and then you wait 15 to 30 minutes and you repeat step 2, which is remove 3 to 5 mLs every 10 to 15 minutes, right? And we typically go a little bit lower. I'll do like 1 to 2. There's no rush. Not going anywhere. Patient's not going anywhere. So step 4, once the air has been completely removed from the band, confirm bleeding has stopped. Unfasten the band because it's going to be velcroed. And then you remove the band by lifting slowly towards the palm of the hand, and then apply the sterile dressing. So just like you would treat a femoral access site. And that's it. Questions?
Yeah.
End. Go ahead.
Are the Seattle's offering any of the different cats, like the nitric oxide and the CO2 and nothing yet?
I think all that is inpatient. Oh, you mean like the rotablator and
No. Well,
yeah, we do have a device that uses that nitric oxide. Yeah, and it's a rotablator and
But
it's
for diagnostics, no. Like instead of, for example, patients that have like renal failure or
yeah. I mean we stented renal arteries before too.
because I've seen recently some of that they use like nitric oxide and CO2 and stuff like that for diagnostics
Mm-hmm.
instead of contrast. I would think that they're the younger Seattle.
They're on their way.
Yeah, they haven't said anything like that.
So, I guess you're gonna show the pictures, right? Porque Eric quería ver las pictures. Were you able to load them or no?
No, do you have them?
I do.
What pictures?
Pictures.
Yeah, I'll show them. Just a second. I'm sending
Please hold.
el video. Huh?
Please hold.
So
Please
what pictures
hold.
did I miss? I don't remember.
Oh,
From the
these are the pictures you want.
Oh, I want to. Yeah, what
So
happened?
the thing is,
Hematoma.
the cath lab.
oh
they
yeah,
bring you the
hematoma.
patient- They bring you the patient and they don't tell you anything. They don't immobilize. They just send you the patient and they tell you, we'll be back in 3 hours to remove the band. So this patient gets to us at 11 and by 2, of course, she chugged in all the lunch food and then she started vomiting, but she didn't move the hand. The granddaughter was helping. But when she vomited, I guess she did a lot of pressure or something. So that's the initial picture. And then it goes to, they came over. I called a cath lab. They come over and they place a second band, right?
Yeah.
To stop, like, if the bleeding was happening over there. And with the second band, Ricardo makes rounds and he was completely mad. Y llega Joaquín y pone una third band. So now we have small, and large band, like large in
Size.
in length. So after the third band, we place a mobilizer, which is basically just some plastic it's un cartón, like cardboard with plastic, and you just place it like so on the patient. It's about this big, right? So I placed it on the patient and you can hardly see, but there's some edema there.
Yeah.
And I already removed the thing. You can see all the edema pulling up there. Again, aquí se le ve el edema. She's going home today. I mean, that day. And then after I placed the board even a little bit higher to get rid of the edema up here, yeah, the arm looks more even.
In those cases,
And that's how she went home.
I thought that we can't do anything about the edema because what's happening is that the hematoma is occluding the venous return. So everything's just kind of third spacing from there.
What they said is that Charlie said to whenever you have here a blood loss of 5 ml, it looks like if it was 30 or 50. But that's because it's smaller, this area, compared to your,
So what did they all
Nada, they just applied, after the first time, they applied the second and the third, and that was it.
What do you think happened?
I don't know, I feel like like when she was vomiting, she did some kind of effort and maybe, like you grab on the bed or something and that's what happened. Because she didn't come with an immobilizer.
You can see
And
it
my
said, so
orders
the
were, we'll come back in 3 hours to remove it.
really
If having had received another one before saying, we'll be back in 3 hours to remove it. It isn't Jose that you have to do like 2 hours and then start going down on the earth.
luckily
Yeah.
mine though, everything was good.
Yeah,
So
and
Nothing
that's-
happened.
What can we do to like avoid that? Because I hate going back, but for example, in other places I was at, the nurses would.
yeah. So all this is for is to transfer the post-op care to the bedside nurse.
Yeah.
Because that's the only way that we're gonna get a success and avoid these things to happen.
Yeah.
The only really reason why I'm here is because Dr. Joaquin asked me to.
Yeah.
Because there's no need for us to risk like loss of limb or anything like that because the bedside nurse is just not familiar with it. Right? Not necessarily acceptable in the
When did you say that
Here.
to remove was coming?
next week.
Next week?
I'll give you his number.
Pero sabes que we do need orders porque just wait and I'll
Wait
be
for
back
them
in
to
3
come.
hours. That's a little.
Yeah, no. So
Like, we need like I would say like a competency check off or something where.
well
All we
the
needed were those instructions. After
On-
2
on
hours.
how to do it. Yeah,
Or-
2
or
hours.
yeah, those are and there's like pamphlets where to remove
Yeah.
like this is literally copy paste. My presentation is probably legal. Plagiarism.
Plagiarism.
Yeah.
But what I'm telling you is like these people, Cat Lab, they do have these instructions. I'm assuming.
Right.
Why do they come over 3 hours later? And then when I call them, because the patient gets here at 11,
I
right?
don't have those answers. for
I
you.
know. But what I'm
I had
trying
them on their
to
lunch or something.
what I'm trying to ask is por qué no tienen ellos el protocol de 2
Mhm.
Like
hours
the sheet.
instead of 3?
I'm sure they
That's-
do. I'm sure they do, but the
But
problem
what I'm
here
saying
that
is
we
like
need
you're not
to
gonna have Cath Lab's not gonna come
Es que te digo,
like we already learned this, right? So we know that after either an hour or 2 hours, we're gonna start withdrawing 2 to 3 mLs at a time.
but I don't have orders to do that.
Sure, right. I understand you don't have orders.
Like I want
And
to do
that's
it.
why you can build a protocol or a policy in place. I will supply Jupiter, you, Eddie, whoever, with what we use, and we also have a little diagram sheet where it's like a little assessment thing,
That's
which
the
I
only
hate
way.
because I don't like paper charting. But
Porque mira,
I'll fill that one out.
they didn't send el immobilizer.
Mm-hmm.
They say they're coming in 3 hours. At 2:30, when the patient
Mhm.
already vomited and whatnot and
Right.
things formed, I call and they tell me we'll be there at 4. What? You said
Yeah.
at 3? Like I'm closer to
Right.
3 than at
Because
4.
usually
So
like
that's even
the
more time.
the transfer is related to bedside. Like Cath Lab la pone and then they just leave.
And we're
Cath Lab's not gonna come every 15 minutes to remove 3 mLs, right?
no,
like
no,
we're
we're fine with
like
that.
we can that can be established, right? We know that's not gonna happen.
And we can do it, pero I just need to know what to do. Porque
Yeah,
si
you're
nomás
right,
dice,
yeah.
you know what, don't touch anything, I'll be back in 3 hours.
Right.
Okay.
Yeah.
I don't even know those things. I understand it's
Mhm.
pressure. I read que dice 12 mLs were in.
Right.
Pero, and then the lady says, I think it's too tight. What am I supposed to do? It's supposed to be there for pressure, but I'm completely
Yeah.
blank about it. Hey, don't worry, I'll be there in 3 hours.
I think
And
even,
that's what
yeah,
the order says.
the goal here is to, como dice Jose, transfer that care to the bedside nurse. But before they do that, the bedside
So like
nurse
what
has
we
to
have,
competent.
we have orders for. So what happened is you got orders post-op for a femoral cath, and in writing it said, cath lab will remove it, right? So that's where the flaw is.
And that's all. See,
So,
that's all. We'll
We
be
have
there.
orders for TR band, like radio only. We have orders for radio diagnostic. We have orders for radio PCIs because they're different.
So we need a transfer of those orders.
Right,
to
sure.
us.
I'll give you those. Also it's a little assessment sheet. I have it
Do
here
you know who's like taking care of this stuff before they come next week, or is anyone taking care of
of what.
like developing something like a training for the nurses? Because I would hate for this guy to come next week
Mhm.
and the nurses just be like, "What the hell's the TR
What's that?
You know what I mean? Like,
Yeah.
just for them
Well,
to
that's what
have
this
like
is
a little
for. That's what
background,
that's what this is
I
for,
hope
so
they
that you
follow me,
familiarize with what the TR band is.
So this is the first time that we get this kind of
Right.
in service,
Mm-hmm.
pero it's because of what happened.
Because of what
I hope they
happened.
do come because
Yeah.
then one of them that probably
Porque,
doesn't care is gonna end up with one and then.
no, porque nadie había tenido problemas until this time. Y también porque, sí,
It's a big responsibility to take up
son
on the
que no
nurse if you don't
saben
know
limpiar.
something know how to use.
Because it's like Impella, who's gonna remove Impella, have a return account, they close the doors, okay.
Yeah.
Pero-
So this
pero
one's
this-
different because it transfers the care over to the bedside nurse, and then you have control of that situation. So you remove some air, and if it bleeds, you just push it back in.
Yeah.
Sí, pero if you give me this information, cuando me das al paciente, pues maybe I'll know what.
Yeah, right. So there's
Pero
also
otherwise
needs to
I'm
be.
just like,
I think that's
They're
the
coming.
goal with it, right? That's
And
And
what
that's
we're
the
trying
that's
to
the
do
thing.
with
So
it.
we get the same type of, because I spoke to Jupiter and I told him, hey, the Terumo guy next week, whatever. And he's like, are they already using this in the hospital? And I was like, yes. And he's like, well, why didn't we get? I don't fucking know. I don't know why you didn't get an
Yeah.
instruction.
because you
But I'm
didn't ask.
here. I'm telling you this, and I'm hooking you up with the Terumo guy so that you can get it.
The reason why we
That's
didn't
it.
know probably was because there was gonna be an order that said cat level
No.
trigger, you know.
Yeah.
But then
Why didn't you wake up with
You
the
have
board
to
today?
know.
I have no idea.
See, but then we just got
Out of my
this
control.
issue, it was I mean,
Oh, yeah.
Joaquin was very scared, Joaquin didn't want to
Wasn't
send
this
the
guy
me
Perfect
paper.
this
mandas,
morning.
me mandas las orders.
Yeah.
So I could plagiarize.
Yeah, and then we also have a policy.
That way, whenever
Mandola
when the Terumo guy comes, there's at least something for the nurses to say like, oh, something's backing us up, you know.
Yeah.
It'll be like a preliminary protocol.
Yeah.
Exactly how it says there.
you just have to just change it really to
To radio.
like, because ours says like, oh, discharge patient,
Yeah,
whatever.
I'm gonna tell them that it's just like a preliminary one because I know you have to go
Yeah.
through the whole CMS and all that kind of bullshit to get approved.
Sí, pero
At least it's something.
You know,
Maybe like a guide for the nurse to follow.
How to.
Yeah.
When
It
she-
sounds funny, but
Yeah.
maybe that's what the approach we need to take. you know?
Oh, yeah.
sí, porque, it just feels like you're completely out of it.
Yeah.
Tesla will come in 3 hours.
I
okay?
remember when we first started with the Impellas, that was the same. That's the same way.
Yeah.
Everything's done. Like they do it, and then they tell you, "Oh, this is what this is," and you're like, "What
Okay.
the fuck is this?"
Sí. Mhm.
So
Everything done in the dark. Ito na
But
lang
yeah,
kasi
so I'll look for it. I know she emailed it to me.
I had some questions about. Oh, as far as would you say that most people know how to manage like a Cordis and all that stuff here?
No,
Cordis.
That's a good joke. That's a very good joke.
that's tomorrow.
Nada.
Oh, you're gonna do that tomorrow. Oh, that's true.
No.
Right? There was gonna be a song.
Mhm.
Okay. That's all I was.
I mean, and these are, I know that they're like really inconvenient
La
because
única que sabe es Rowena. That's it.
I just got tasked with this like last week, and I really have one more week left here. So that's why they're like bolus classes.
Yeah.
Dude,
Otherwise, they'd be more separate.
More thorough.
It's pretty thorough.
No, I mean like in more classes. Well, it's because it's thorough.
Yeah, just
I feel
spaced
that
out.
It's thorough for me because I know what you're talking about.
Pero we need
But I don't
like
know.
baby nurses explanations.
I haven't met most people here, but as far as
it's just
No, we
Most
have
people that talk to
everyone
me,
new.
yeah.
We have everyone
so
new.
maybe we, just I guess.
Por eso le pedí que si nos ayuda también con el ventilator refresher. Porque ahorita que estaba hablando del metformin, for you it clicks, for me it clicks. Y la gente nueva they're going to be like,
That's why I was
they're
asking
speaking
those stupid
metformin.
questions.
Yeah,
No,
for sure.
Basic questions. We need to ask basic questions for all the people que no puedo venir.
consult someone. Yeah.
Well, I'll look for it, te lo mando. There's a policy there, and there's like the orders.
I can't read it. 15 to 18 cc air.
Sí, so ahorita me,
So
it was RC that called me,
Oh,
and I was like, she's trying to give me shit or something.
Why?
And he's like, Jose, why isn't Wednesday pronounced Wednesday? Y dice que es que una vez un negrito lo dijo así, y así se quedó. And I was like, oh, okay. He's like, I thought you needed to know that during your presentation. Y le dije, ahorita voy a ir a Cath Lab and I'm gonna get a TR band under your name, just so you know. Está bueno. So,
Nice.
do you guys want to take a break?
What are we gonna do next?
The next one is on the vent.
Oh, okay.
Yeah,
Hola,
it's the same one there.
¿La vas a traer o?
I have it right here.
Ah, ok.
I have it right here.
No, what? La banda no te la
Oh, la banda. Cath Lab's not here yet. No, this is the other one.
Ah,
So the terms that they use here were
Ah, yes, yes.
preserve,
Kim,
basically,
Alexandra,
though they used.
I'll play that. I'll play the video for you right now, Kyle.
Yeah, it's like
Once we're done.
legit everything that.
Oh, let me play it right now.
Yeah, you can figure it out.
Let me play it right now. I play it right now.
Carla.
Is that okay?
Carla.
Just short video.
For 6 minutes.
Stasis Addition and Removal Hospital in Albany, New York. Today, we're going to be discussing the application and removal of the TR band. The TR band is used to apply low pressure
Yeah.
hemostasis
So
at the
everyone
site of
got
the
me
radial
this
artery
first?
access and sheath.
How come no one's
We'll discuss the
educated us?
importance of the
That's
barbell and the reverse
So, yeah,
barbell
same question.
as it
So
pertains
can
to
an educator?
Right back at you.
of the TR band. And the reason why
Oh,
we
it's true.
low pressure
Nomás
hemostasis
es este, yo
is to attempt to reduce the incidence of radial artery occlusion following radial artery catheterization. Although radial artery occlusion is thought to be rare and mostly asymptomatic, it is important when we are dealing with re-access of the radial artery.
No, I
Low
traje
pressure
uno.
hemostasis or heat hemostasis enables blood to flow through the radial artery while pressure is applied in order to reduce the likelihood of radial artery occlusion. To assist with managing hemostasis, Terumo has developed a
Oh, we're
dual
watching
radial
this.
artery
Oh, es
pressure
que Carlos
device
quería ver.
designed to help manage the cessation of bleeding
Oh, you're
under low volumes of pressure.
Thanks, Eddie.
In addition, the TR allows the user to control the pressure applied by giving minimally penetrating air
Carl, do
throughout
I
the
have your
recovery period.
email?
The TR is
I don't get it.
Can I have your email para send you this?
currently
Oh,
and
yeah.
consistent hemostasis
I'm
and
writing down,
maintenance
yeah.
of low pressure.
No, I saw it back here when I
So,
was
but you
doing
know
my-
you can give me his email?
when everyone was in the
After removing
Oh,
the
okay.
we will withdraw the introducer sheet
Yeah.
about 2 to 3 centimeters in order to properly place the band on the patient's wrist so that there is no obstruction when seating the band. The TR band must be positioned differently when
This
used
is
on the
all
left or right wrist.
Doctor stuff.
When attaching the device,
Anytime it's radio,
ensure that the tremolo
you'll never
logo
get the
on the
patient
support
with the
plate
sheet.
is closest to the patient's little finger or ulnar side of the wrist. It is also important to align the green marker about 1 to 2 millimeters proximal to the puncture site and fix the strap on the wrist with the adjustable fastener. The green dot is located on the center of the compressor.
Maldita, mira, you see that
Placement of the green dot
immobilizer on the bottom?
because
The one that they brought me was smaller than that,
located.
but they brought it afterwards, like once she had a hematoma. They didn't
Now
bring
that the
it
band
like,
location is
you know, on a
properly
right-
secured, I will fill the inflation syringe with 15
no,
to
me
18
lo trajo Lala.
mLs of air
Ah,
Me lo trajo
okay.
Lala, pero te digo, once again, no instruction más que, they will come at 3.
into the air port of the TR band
Y cuando
and
le
simultaneously remove the radial sheet.
The
The air will be fully inserted when the sheet is completely removed. The goal is for bleeding to cease when the sheet is completely removed from the patient's artery. Once we have fully inflated the TR band and confirm that bleeding has stopped, we will now ensure patent hemostasis. We will do this by removing 1 cc per second while keeping an eye on the access site to watch for bleeding. Once we see a flash of blood, we will inject 1 to 2 cc's of air back into the brain incrementally until bleeding stops. This will help.
So that one's important because that's also what you're gonna